John and I have been working on this for quite a few years now. We're from the University of Lincoln. We developed the cognitive DAISY, and I would like to talk a little bit about where we come from, how it was developed, and then about the latest study that we conducted. Very briefly about the statement of the problem 10 years ago or so. We were doing some care home research, not related to this, but we wondered what the general knowledge is of care staff about the cognitive problems that people with dementia experience, and particularly about the individual differences about cognitive problems. And they are obviously influenced by the type of dementia, the subtype, the stage, cognitive reserve, etc. We also learned, or we acknowledged, that it is important for care staff to understand the individual cognitive profile of people with dementia in care homes. But there seemed to be a problem, and that is that not all training is focused on individual cognitive profiles, or it's not really covered that much in depth. And also, when people enter care homes, there might not be a lot of information about specific cognitive problems that that particular person experiences. So we thought, how could we address this? How could we make a contribution? And we thought visualizing a cognitive profile might be a really nice idea. And that's what we worked on in the next several years. So what is the cognitive DAISY? It is a visual representation of a person's cognitive profile. The idea was to not just highlight the problems that a person experiences, but also the cognitive strengths. So it's based on, we developed a cognitive assessment battery, which is derived from standard neuropsychological assessments that are, by the way, freely available. And it's not a diagnostic tool. The purpose of the cognitive DAISY is really to support care. The tests that we've chosen were developed with in mind to highlight the problems that a person might experience in daily life. It can be used also to monitor fluctuations. We also want to highlight that it doesn't say enough by itself. You should always consider observation and life story booklets in care homes, etc. But we thought it would be really important or useful for communication, but also for care staff to have an instant view of a person's cognitive profile so that they can respond to individual needs in the moment. So as you can see, there are 5 colors, 5 cognitive domains, and there are 15 tests focused on one specific cognitive function within each of these 5 domains. So how can it be used in care homes? These are some examples. The colored petals represent cognitive problems, and the white petals represent cognitive functions that are not as badly affected or not affected at all. So it also allows you to talk not just about problems, but also about strengths. So we've piloted this in the Alzheimer's Society in Lincoln, and they found it very useful to talk to people who were just diagnosed with dementia, to not just focus on the negative, but also on the positive, and how can these white petals support you in continuing to do what you like to do. The grey petals indicate that the test could not be done for different reasons. It comes with a training. There's 2 types of training. One is focused on how to use the DAISY in the care home. So carers, when you see a DAISY, what can you do with it? And then there's a second level where more senior staff is being trained on how to actually conduct the assessments. It comes also with a petal-by-petal guide. So we developed this together with occupational therapists, and for each petal, for each test, we have We translated it in, so if a person has a colored petal, what kind of problems might this person experience in daily life? That's on the left side. And then on the right side, we, together with the occupational therapist, we came up with a list of potential approaches that a carer could use to support this person. So I would like to talk today about, because we did extensive pilot work. We've been we had meetings with a huge amount of voluntary organizations to just get an idea of what do you think of this idea? Is this meaningful to you? Do you think it's useful? And over the years that we developed it, we had so much positive input and so much positive feedback that we could continue to work on it. And we did a pilot study initially in care homes, in 6 care homes, to ask staff, what do you find useful about it? Does it help you in providing care? But that was a very short trial. And so, supported by all this positive feedback, we applied to NIHR, who gave us support to conduct a larger trial. And the focus of this trial was to find out whether the protocol that we had was going to be suited for a future larger trial on the national level. So the initial, or the primary objective, was to find out if we could recruit the necessary number of residents, if we could recruit the care homes and also the staff. And then there was secondary objectives to find out if we could find any outcome signals of effects. So we had a whole range of outcome measures, and we did a process evaluation to find out the facilitators and barriers. And we did this together with Leeds Beckett, with Claire Sir, and with people from Hull, their Health Trials unit, and some more people of Lincoln. So the design was like this. It's a cluster randomized control trial. I won't go into too much depth, but we had care homes who were randomized to the intervention and care homes who were randomized to act as control homes. We did data collection in both homes, the same tests. For residents, we recruited by proxy, so we asked staff to provide measures on the residents' behalf, and the staff completed their own questionnaires. We started with a cognitive DAISY staff training. Again, there's 2 types of training, one for all care staff and one for assessors. And then we did the cognitive DAISY assessments with the residents at the beginning of 6 months, and then again 6 months later. And at the end, we had focus groups and interviews with residents and staff and managers and family members. So I'm going to fly through these results. Our target, or one of the important things, was to see if we could actually recruit so many people. And our target was 100, and for the staff it was 50, and we over-recruited, so at one point we actually had to stop recruiting. And so this is kind of like a typical way to represent whether the trial would be feasible. So there are feasibility criteria that you either, you specify in advance. So we looked at whether the cognitive DAISY assessments could be completed. So we looked at the completion rate, and that was all green. The staff training, the completion rate was also green. So initially, there was a lot of interest in the training, and staff really enjoyed it. And I'll say a little bit more about this later. So there were some key candidate outcome measures. There was a whole list of questionnaires and measures that we used to find out if there were any changes if we compared the control care homes and the intervention care homes, but we didn't really find any big differences. 2 measures were our key measures. One was agitation. It's a questionnaire which measures, well, several items that measure different aspects of how agitated people are in the last 2 weeks, and then there's quality of life questionnaire. We didn't really see any major signals of impact. And one of the well, aims of a feasibility study is also to find out if this type of data collection actually works. So that was okay. So by proxy measures, etc., that was quite successful, but the actual effects of impact were not really very clear. So one of the other things that we did was a care plan review. We wanted to ask staff, this is one in the pilot study, care staff mentioned that it was really useful for informing care plans. And so we did a care plan review with some of the senior staff. And when we did this, then we found some really interesting recommendations. So some of the topics that were discussed involved discussions about attention, for example, resisting distraction. So one of the kind of novelties or the new discussions that were opened up in the care home was the role of noise and the busyness around meal times and how that might affect their memory performance and just general well-being. There were also some really quite specific cases, people who had very unusual object recognition issues. Some people have spatial awareness issues. Some people had face recognition issues, and this raised some discussion in the care homes among the staff. So, for example, there was one lady who couldn't recognize a fork in the actual assessment, an image of the fork, and that also translated in real life. So they weren't able to use the fork during mealtime, and that had some impact on how much they would actually eat. So by knowing this, then care staff could respond to that by using hand on the hand training. One of the key barriers was that not all staff was involved in the trial, so the senior staff who actually made the care plan reviews were a little bit reluctant to make these changes. So this is something that we have to bear in mind taking it forward. These are just some examples of daisies. We also take information about hearing and vision. And one of the interesting things that we found was that it's actually quite different. It can be informative at a care home level, how many problems there are or how severe problems are, and we also found that in the average scores. By the way, the center, the orange circles in the center represent speech problems, so we have a different version of the assessment for people with speech problems. So we did a first and a second assessment, and as you can see, there weren't that many changes, so that might indicate that the test might not be sensitive enough to pick up these very small changes that occur over 6 months, and that's not surprising because it's actually when we tested these assessments in the community for people of 75 years and older, then most people achieved ceiling, so it's not that sensitive. So process evaluation very quickly. So I think the staff really enjoyed it. They really enjoyed the training. They learned a lot. They also found it quite easy to do the assessments with the residents, and even though they needed a little bit of time to get used to it. Some of the comments of the staff were that they were surprised by the abilities of the residents, which was a little disconcerting. So they also said that it was more useful to actually be involved in the assessment process. They learned more from that. For relatives and residents, some residents thought it was a little childish, and other residents found it very difficult, but almost all residents enjoyed it because it is a very user-friendly booklet. It's colorful. It's done in a nice, comfortable environment. And yeah, the relatives were also very positive about it, but recognized that it's a time issue. So as I mentioned, the use of the cognitive DAISY by staff was a little bit limited because of time pressures. I think that's what we had to conclude. It's although they really enjoyed it at the start, when they started to use it in daily life, they found it difficult to find the time to think about it and to learn about it. So, and then we also had an issue with transition to e-care planning, which happened at the same time. So that made some of the care plans or the DAISYs less accessible or less useful. So that was a bit unfortunate. So to conclude, it was a very successful recruitment protocol. Initially, it worked very well. The staff really enjoyed it. The residents found it acceptable to do the assessments and sometimes enjoyed it. But I think there are still some issues that we need to work on. Time is a real issue in care homes. Staff just didn't have the time. And I also think that management buy-in is very, very important. And not all managers in our study were really keen on being involved in this. So that was a bit disappointing. And I think that's it. These are all the people.